Hope, all are doing well. So myself, I am Siriyya. I'm a critical care nurse manager in Continental Hospital. So today I'm going to discuss regarding the basics of arterial blood gas analysis. So we'll move on to the presentation. Okay, ABG. What is the why we are doing the ABG? So an arterial blood gas test measure the oxygen and carbon dioxide levels in your blood as well as your pH balance. That is the main reason for the doing the ABG. So for doing the ABG, what are the equipments we need to get it done the test? First one, gloves and apron, pre-heparinase syringes, which is dry heparinase syringes. Next, ABG needle, which is 23 gauge, alcohol swabs to clean the area, gauze piece, tape or plaster, lidocaine 1% for giving a local anesthesia, a subcutaneous needle 25 to 27 gauge, small syringes for the giving the anesthesia, and last one is sharp container. So these are the main equipments to get it done the procedure. Next, here we can see method and the way how to collect the ABG sample. Here in the picture we have shown the arterial ABG for the radial artery. So the angle, you can see that 45 degrees angles we have to use, and as well as the see the Allen's test, the flow of the blood also. According to that, we have to collect the sample. Next, this is the scenario how to collect the ABG. Perform the Allen's test. Next, followed by the feel the radial artery with non-dominant index and the middle finger. So using that both fingers, we have to feel the pulse. Then take the swab, clean the area where you are going to do the puncture. Hold the syringe like a pen and go in at a 45 degrees angle. As I said, you have to use the 45 degrees angle for the collecting the radial artery. Puncture the site distal to the two fingers within the bevel upwards. So in that needle, we have to show the bevel upwards when you are puncturing the artery. The syringe usually rises by itself. It means the pressure in the artery, the blood will comes in the syringe. Next, collect about 2 ml and take the needle out. We have to collect the 2 ml of the ABG, and then soon after that, take out the needle and apply the pressure for 3 to 5 minutes. So here we can see the few sample errors. So commonly the sample errors are air bubbles. So before doing the ABG, we have to clear the air bubbles. So by you can see the picture. So how the nurse is taking out the air bubbles. And here, what will happen if the air bubbles are present with the blood? So air bubbles with the blood will increase the PCO2 and decrease the increase the PO2 and decrease the PCO2. So, and one more thing is very important, how to transport the ABG sample. There is a certain temperature, room temperature, we supposed to transport the ABG sample for to the ABG machine or laboratory. So here the importance of the temperature we have shown here. As I said, a room temperature we have to maintain for the transport of the sample. Otherwise, the results will get a few changes. So what are the common complications of the procedure? So when you see as a like a healthcare professional, we know that the local hematoma, if you are not giving the applying the proper pressure or you are giving a too many punctures for the ABG, there is a chance of developing a local hematoma. Artery vasospasm, arterial occlusion, AR thrombus embolism. Next, infection at the puncture site. Infection at the puncture site, we can see if you are not using the proper aseptic techniques without cleaning or using any used cottons. Okay. Next, vessel laceration, vasovagal response, hemorrhage, local pain. Pain at the site is common. For that, we are using the local anesthesia. Needle stick injury to healthcare personnel. So this is the very common one to get the needle stick injury. So there is a no recapping method. Kindly dispose the needle into the PPC soon after the collecting the sample. So what are the values we can get in the ABG? In the slide, you can see first one is pH, PCO2, PO2, bicarb, BE, and saturations, O2 saturations, electrolytes, sodium, potassium, calcium, HB, and met HB and carbonated HB lactate. Next, these are the normal values of a ABG. Here we can, as I mentioned, what are the things covers under the ABG? These are the normal values for the pH 7.35 to 7.45, PCO2 35 to 45, PO2 70 to 100, SO2 93 to 98, and bicarb is 22 to 26. For Anderson's formula, we can see this pH is like increasing along with the pH, the bicarb also, HCO3 also will increase. And if the going to the PCO2 is decreasing, then pH will increase. Next, we'll go step by step the ABG analysis. First one is assess the pH, and the second one is determine the primary acid-base abnormality in this respiratory and metabolic, whatever it may be, respiratory acidosis or respiratory alkalosis, or otherwise metabolic acidosis and metabolic alkalosis. And third one, determine metabolic involvement. So assess the bicarb and the BE. Assess for the compensation. Okay, we have to see whether is it a compensatory mechanism. See the compensation. Further evaluation in case of metabolic acidosis, calculate anion gap and delta ratio. Moving to the next slide. So here we can see the pH changes. If it is pH is less than 7.4, it will comes under the acidosis. And you can see the other side, pH is more than 7.4, it comes under the alkalosis. As I said, acidosis, there are two types, metabolic acidosis and respiratory acidosis. In metabolic acidosis, bicarb levels will get less than 24, and respiratory acidosis, PCO2 levels are more than 40. Coming to the alkalosis, here there are two types of there, metabolic alkalosis as well as a respiratory alkalosis. Coming to the metabolic alkalosis, bicarb is more than 24 and respiratory alkalosis, PCO2 is less than 40. So here the flowchart we can see how the pH levels are decreasing and pH levels are increasing. In acidosis, pH levels are decreasing, and alkalosis, pH levels are increasing. So according to the pH levels and PCO2 bicarb levels, we can see the acute and chronic effects. So first of all, obtain the relevant clinical history. Is there any known case of the hypertension, CKD, or any renal issues, respiratory issues? We have to see the relevant clinical history. Determine the pH. Same as pH, if it is into alkalosis means increasing of the pH, acidosis is decreasing the pH. According to the PCO2 and HCO3 increasing and decreasing, we will see the alkalosis of respiratory alkalosis and respiratory acidosis. Same as like a metabolic alkalosis and metabolic acidosis. Here there is a same graph, so but it is in a different way. Next one, primary disorders and compensation. This is a very important slide. So where how the compensatory response is working. He see acid-base disorder, initial chemical change, and compensatory response. In this acid-base disorder, respiratory acidosis. In the respiratory acidosis, what is happening to the PCO2? PCO2 levels are increasing. As a compensatory response, in that bicarb is also increasing. Coming to the respiratory alkalosis, PCO2 is decreasing. So for that, the compensatory response is the bicarb also getting decreased. Next one is metabolic acidosis. Metabolic acidosis, the HCO3 is decreasing. In the as a compensatory response, PCO2 also decreasing. And last one, metabolic alkalosis. Here bicarb is increasing, and as a compensatory response, the PCO2 also increasing. Next slide. Condition that cause the respiratory acidosis. What are the conditions mainly causing the respiratory acidosis? Airway obstruction. So here there are multiple causes are there. Central causes, peripheral neurological causes, lung disease, and chest wall causes. Here we can see central causes, which are related to the brain injury, stroke, it is ischemic or hemorrhagic, trauma, drugs, anesthetic, and sleep apnea. These are the causes under the central causes. Next, peripheral neurological causes. Nerve injury, spinal cord trauma, phrenic nerve palsy, neuropathy, GBS in that polio, motor neuron disease, epidural abscess. Coming to the lung diseases, COPD, asthma, pneumothorax, pulmonary edema. Last one, chest wall causes. Deformity of scoliosis, flail chest, obesity, muscular weakness, electrolyte imbalance, myasthenia gravis, and muscle relaxants. Next, coming to the condition that causes the respiratory alkalosis. For the respiratory alkalosis, what are the causes? Again, central causes, pulmonary causes, cardiac causes, and others. Here we will see the central causes. First one is head injury, stroke, trauma, hyperventilation syndrome, pain, fever, and stress. Pulmonary diseases, pneumonia, asthma, fibrosis, ARDS, pulmonary embolism, and important one is hepatic failure also. Next one is cardiac causes, myocardial infarction, heart failure. Others are the hypoxemia, drugs, sepsis. So metabolic acidosis, there is a anion gap. So the principle of electro neutrality. So here we will see the sodium, potassium, calcium, and the bicarb levels. See the formula: sodium plus potassium minus calcium plus bicarb. Usually the levels is 10 to 14. If it is normal in a range, that we will call it as a nagma, and if it is a more than range, more than 14, it is call it as a high anion gap metabolic acidosis. So normal anion gap, nagma. So here hyperchloremia, GI losses, vomiting, diarrhea, renal losses, renal tubular acidosis, and next one is hydrogenic sodium chloride. As I said, high or increased anion gap metabolic acidosis, which is called as a HAGMA. So increased unmeasured ions. Here one mud piles. Okay, this is a simple way or simple formula to remember. Here methanol, uremia, DKA, propylene glycol, infection ion. Next one is lactic acidosis, ethylene glycol, ethanol, and salicylates. Corrected anion gap. So here we can see corrected anion gap, the hypoproteinemia common in critical illness. So there is a hypoproteinemia is very common in the critical illnesses. Here we can measure the albumin has a lot of negative charge. So for that albumin gap, we'll see here albumin gap that is equals to 40 minus apparent albumin, and anion gap is equals to albumin gap plus albumin gap divided by 4. Delta ratio is equals to delta albumin gap divided by delta bicarb. Here you see less than 1 is a HAGMA and NAGMA, high anion gap metabolic acidosis and normal anion gap metabolic acidosis. If it is a more than 1, what will happen? Metabolic acidosis and metabolic alkalosis. So causes of the metabolic acidosis. There are multiple causes. Here see addition of base of the ECF, excessive alkaline ingestions, massive blood transfusions, and volume depletion. So next one is chloride depletion. So loss of acidic gastric juices and the diuretics. Next one is potassium changes, hyperkalemia and Cushing's syndrome, hyperaldosteronemia. Metabolic alkalosis. What will happen if the metabolic alkalosis? So confusion will be there, and dizziness means a weakness, and next one is increased irritability, nausea and vomiting. These are the main symptoms, and increase in the anxiety. Next one is metabolic acidosis. In the metabolic acidosis, we can see the headache, decreased blood pressure, hyperkalemia, changes in loss of consciousness. Next one is muscle twisting. These are the main things: DKA, severe dehydration, renal failure, and shock. So here we can see analysis of acid-base problems. For the analysis discussion, here we have our head of department, critical care HOD, Dr. Ramesh. He'll lead the session for the analysis.
So I hope everyone has understood how to analyze the interpretation of ABG. So first we have to find out whether the pH is less than 7.4 or more than 7.4. If it is less than 7.4, it is acidosis. More than 7.4, it is alkalosis. And next, if it is less than 7.4, whether it is respiratory acidosis or metabolic acidosis. In respiratory acidosis, mainly the carbon dioxide level will be higher side, and in metabolic acidosis, the bicarb level will be lower side. So after diagnosing as a respiratory acidosis, we will see for the compensation, whether it is a chronic respiratory acidosis or acute respiratory acidosis. In case of acute respiratory acidosis, the compensation is for every 10 change in the carbon dioxide level, 1 change in the bicarbonate will be there. In case of chronic respiratory acidosis, for every 10 change in the carbon dioxide, there will be 4 change in bicarbonate, 4 increase in the bicarbonate. For example, if the carbon dioxide is 60, the bicarbonate will increase from 24 to 32. That is 8 will increase. So that's how we'll see based on the compensation. We'll classify that into acute respiratory acidosis or chronic respiratory acidosis. Now, if the bicarbonate is low and if you are diagnosed as a primary metabolic acidosis, then again we have to look for the compensation by the formula 1.5 into bicarb plus 8 plus or minus 2. So in that we'll see whether it is compensated or uncompensated. After that, again, if the pH is more than 7, again, if you are diagnosed as metabolic acidosis, then you have to classify it into high anion gap metabolic acidosis and normal anion gap metabolic acidosis based on the anion gap what we calculate. That is sodium minus chloride plus bicarbonate. So coming back to the alkalotic part, if the pH is more than 7.4, again in the respiratory alkalosis, if the PCO2 is less than 40. In that also we have acute respiratory alkalosis and chronic respiratory alkalosis, wherein 2 is the compensation for acute respiratory alkalosis and 5 is the compensation for chronic respiratory alkalosis. That is, for every 10 change in the carbon dioxide, there will be 5 change in the bicarbonate levels. So if the bicarbonate levels is higher side, then we'll classify that as a primary metabolic alkalosis, for which the compensation is 0.5 into bicarb plus 21 plus or minus 1.5. So based on that, we'll classify that into compensated metabolic alkalosis or uncompensated metabolic alkalosis. So now let us go back and check with few cases wherein we'll analyze and see how to go ahead with the analysis. So this is our first case. He is a 55-year-old male patient presented with left MCA infarct. He was in severe dehydration and raised creatinine level also. He was in acute renal failure. This was the ABG. So pH was 7.5, PaO2 was 65, PCO2 was 36, bicarb was 29, sodium was 142, potassium 3.8, chloride 95, lactate 1.1. So Siriyya, whether it is an alkalosis or acidosis, pH wise?
This is an alkalosis because the pH levels are high than the normal. So it will come under the alkalosis.
Okay. So in alkalosis, whether it is a respiratory alkalosis or metabolic alkalosis?
So it's a respiratory alkalosis. Why? Because the PO2 values is very lower side. It is a 67. Sorry, PCO. HCO3 is 29.
Okay, more than the range.
More
so
than
it is primary metabolic alkalosis.
Sorry.
Okay. So here the bicarbonate level is more than 24, that is 29. That is the reason it is primary metabolic alkalosis. Okay, now next we'll see for compensation. That is compensation formula is 0.7 into bicarb plus 21 plus or minus 1.5. So here the bicarb is 29 and like 0.7 into 29 plus 21 that is equal to 40 plus or minus 1.5 it will come. So going back to our PCO2, it is 36 here. So it is uncompensated metabolic alkalosis. Okay. Again to this calculation, the carbon dioxide level should be 40. Our APG carbon dioxide level is 36. So it is uncompensated metabolic alkalosis. Next case, it is a case of a female presenting with CA breast, post radiotherapy and pulmonary fibrosis. She was a bit tachypnic. She was having a respiratory rate of around 25 like that, and she was having like hypotension and tachycardia also.
Okay.
So now her pH is 7.12 and PO2 is around 221. PCO2 is 94. Bicarbonate level is 30. Sodium is 137. Potassium 4.8.
Okay.
Chloride 99 and lactate is 1.4. So first, looking at the pH, it is
acidosis.
Acidosis. Looking at the bicarbonate and carbon dioxide level of 94, it is
high.
Respiratory acidosis or metabolic acidosis?
Respiratory acidosis.
Okay, because carbon dioxide is 94, very high. So now going back to the compensation for acute respiratory acidosis, the compensation is 1 for every increase in the for every 10 increase in carbon dioxide level. So bicarbonate compensation of 1 for every 10 increase in carbon dioxide level.
Yes,
so above 40, like how many 10s are there for 94?
Above 45.
5. So the compensation, if it is acute respiratory acidosis, compensation should be 5 increase more than 24. We have to take bicarbonate level as 24 as a standard. So in this case, more than 40, 50 increase in the PCO2 level is there. So for every 10 increase in the PCO2, 1 will be taken as a compensation. So if it is acute respiratory acidosis,
yes,
1 is a compensation. So about 24
plus 5.
24 plus 5, it is 29.
29.
So it is
more or
acute,
less nearing to the bicarbonate.
So it is acute respiratory acidosis or chronic respiratory acidosis?
Acute respiratory acidosis.
What is the compensation for chronic respiratory acidosis?
It is a 10:4 for the chronic respiratory acidosis.
Okay. So in this chart, we can see the change in bicarbonate level for every 10 increase in the carbon dioxide level. So in acute respiratory acidosis, there will be 1 change in the bicarbonate for every 10 change in carbon dioxide level. In chronic respiratory acidosis, there will be 4 change in the bicarbonate level for every 10 changes in carbon dioxide level.
Yes.
So in this case, it is an acidosis, respiratory acidosis, because the carbon dioxide level is 94. And looking at the compensation, it is acute respiratory acidosis because the compensation will come to 24 plus 5, that is 29. So it is acute respiratory acidosis. Acute respiratory acidosis.
Yes.
This is the third case wherein we have a 65-year-old male patient coming with COPD, background of COPD and breathlessness, cough with expectoration and fever. So his pH is 7.32, PO2 is 80, PCO2 is 80, bicarb level is 40, and sodium is 138, potassium 4.8, chloride is 96, lactate is 1.
Let us see in the chat box, sir. Anybody, any audience, will they guess for the, is it a acidosis or alkalosis?
Okay.
Okay.
Anyone can guess that it is an acidosis or alkalosis?
Yes,
Respiratory acidosis. Okay. Respiratory acidosis with metabolic compensation. Okay. Chronic respiratory acidosis. Okay. So coming back to the case, pH is 7.32. So
Yes,
it
sir.
is acidosis. Carbon dioxide is 80 and
bicarb is 40.
Bicarb is 40. So since the carbon dioxide is 80, it is
Respiratory acidosis.
Respiratory acidosis. Now going back to the compensation, according to the compensation, it is chronic or acute? Carbon dioxide 40
chronic.
plus 40.
Yes, sir. My guess is chronic, sir.
No guess point here.
Chronic,
so 40 plus 40, 80, like above 40, we have 40 PCO2 rise. So for every 10 increase in the PCO2, if it is acute, it will be 1. So 4 increase in the bicarbonate should be there if it is acute respiratory acidosis.
Yes.
24 plus 4, the bicarb should be 28.
Yes.
So that is the reason it is not acute respiratory acidosis.
Correct, sir.
So calculating back to the chronic respiratory acidosis, 4 bicarb, compensation is also 4. So 4 into 4, it will become 16. So 24 plus 16, it will come 40. So it is chronic respiratory acidosis. Okay. So this is acidosis, respiratory acidosis. Looking at the compensation, it is chronic respiratory acidosis. So this is our fourth case, which is a post-renal transplantation patient with high sugars of around 550, and ketones were also positive in the urine.
Okay.
And pH is 7.06, PO2 is 80, PCO2 is 22, bicarb is 6.1, sodium 138, potassium is 4.8, chloride is 102.
Yes, sir.
So now let us see the audience, whichever whether it is acidosis, if it is acidosis, whether it is respiratory acidosis or metabolic acidosis. Audience can use the chat box to answer for this question. Metabolic acidosis, metabolic acidosis. Okay. So all are for metabolic acidosis. Unanimous answer. Okay. Okay. We'll take further. So since the pH is 7.06, it is acidosis. And since the bicarbonate is 6.1, it is
metabolic acidosis.
Metabolic acidosis. What is the compensation formula for that? 1.5 into bicarb.
1.5 into bicarb plus 8 plus or minus 2.
Okay, it is compensated or not? So bicarb is 6, 1.5 into 6 will come to 9, 9 plus 8, 17, 17 plus or minus 2. Okay, so 15 to 19 is the range. So our bicarb was like our PCO2 was 22. So 15 to 19 is the range. Our carbon dioxide is around 22. So it is uncompensated metabolic acidosis. Now again, once it is diagnosed as metabolic acidosis, we'll have to calculate what is called anion gap. What is the formula for that?
So here we'll anion gap PCO2 sodium minus chloride plus bicarb.
Okay, sodium was how much?
138
plus chloride 102, chloride plus bicarb. So 102 plus 6.1. So 108.
Yes, sir.
Sodium is 138 minus 108. How much it is?
20. 138 minus 108.
138 minus 108. So it is
20.
30.
20.
Okay. So anion gap formula is this one. Normal anion gap is 12 plus or minus 2, that is 10 to 14. So our anion gap came to more than 14. So that is the reason it is high anion gap metabolic acidosis.
Yes.
Okay. So you, like as you told, what are the causes of high anion gap metabolic acidosis? You explained here, no?
Yes.
Hmm.
Mud piles, methanol and uremia, and chronic kidney failure, DKA, and coming to the propylene glycol, infection, iron, isoniazide, inborn errors of the metabolism, lactic acidosis, ethylene, glycol, and ethanol. Last one is salicylates.
What are the causes for normal anion gap metabolic acidosis?
Coming to the GI losses, vomiting, diarrhea, renal losses, renal tubular acidosis, and acetozolamide. Next, last one is hydrogenic sodium chloride. Any questions from the audience? We'll see in the chart.
Any questions from the audience? Okay, someone is asking for mixed metabolic acidosis or alkalosis. So after calculating the anion gap, there is something called as delta ratio, wherein we'll calculate the anion gap difference and then the bicarbonate difference. So the delta anion gap and delta bicarbonate ratio, which will give the delta ratio. If it is more than 1, it is mixed metabolic acidosis and metabolic alkalosis. If it is less than 1, it is normal anion gap metabolic acidosis with high anion gap metabolic acidosis. Someone is asking about the compensation of metabolic acidosis formula. So you can see in the screen the compensation of metabolic acidosis. The compensation formula is 1.5 into bicarb plus or minus 8. 1.5 into bicarb plus 8 plus or minus 2. So here you can see now in this 1.5 into bicarb plus 8 plus or minus 2. So that will give the formula for compensation of metabolic acidosis. Any other questions? So someone is asking for so chronic and acute will be there in respiratory acidosis, and in metabolic acidosis the compensation will be same only. Only one formula will be there in metabolic acidosis. In respiratory acidosis, the compensation will be different for acute and chronic. as we discussed. I will show it in the figure also. Here, for acute respiratory acidosis, the compensation of bicarbonate for every 10 increase in carbon dioxide level is 1. And for chronic respiratory acidosis, the compensation of bicarbonate for every 10 increase in carbon dioxide is 4. Okay. For example, if the patient's PCO2 is 60 and the calculation of bicarb will be in calculation in chronic acidosis, the bicarbonate should be 24 plus 8. If the carbon dioxide is 60, that is 20 more than the 40. So the bicarbonate should be 8 plus 24, that is 4 for every 10. So for 20, it is 8. 8 plus 24, that is 32. The bicarbonate should be 32 in chronic respiratory acidosis. And in acute respiratory acidosis, 10 plus 20, that is 60 if you are taking as carbon dioxide. That is 20 more than the 40. So for every 10, it is 1. So 2 increase in the bicarbonate. 24 plus 2, that is 26 should be the bicarbonate in acute respiratory acidosis. So based on that calculation, we'll decide that it is acute or chronic. When to any other questions? Okay, someone is asking for albumin correction of anion gap. Albumin correction is not there for metabolic and respiratory. So only for calculating the anion gap, the albumin correction is there. Wherein the measured albumin plus 2.5 into 4 minus anion gap will be the measured anion gap plus 2.4 measured anion gap plus 2.5 into 4 minus the albumin level will be the correction for the low albumin levels in the blood. So any other questions? If there is no question, okay, so what can in patient with albumin treatment? So whether the patient is in albumin treatment or not, the serum albumin level we will take as a standard. On that we will calculate the correction for the anion gap. Okay, so the measured anion gap plus 2.5 into 4 minus the albumin will give the corrected anion gap for that. Compensation for respiratory alkalosis. So respiratory alkalosis, again we have to divide that into acute respiratory alkalosis, chronic respiratory alkalosis. In acute respiratory alkalosis, the change in bicarbonate for every 10 decrease in the carbon dioxide will be 2. In chronic respiratory alkalosis, the change in the bicarbonate for every 10 decrease in the carbon dioxide will be 5. So if suppose if the patient's carbon dioxide is around 20 and the compensation for acute respiratory alkalosis will be so that is 20 means it is 20 less than the 40 will be taking as a standard. And so the carbon dioxide, like since it is 20 less than the 40, so 2 10s are there in that. So 2 into 2, that is 4. So bicarbonate will be 20 in case of acute respiratory alkalosis. In case of chronic respiratory alkalosis, the bicarbonate will be 10 less than the 24, that is 14 will be the bicarbonate level in chronic respiratory alkalosis. Any other questions? In acute respiratory acidosis, what are the clinical manifestations of respiratory acidosis? In respiratory acidosis, patient will be restless, tachypneic, tachycardia will be there, hypertension will be the response, and they will also feel the headache also. Okay. Any other questions? Okay, if there is no question, we can end this session. Thank you everyone for attending this one. Thanks for the ISCCM also for allowing us an opportunity, for giving us an opportunity from the Department of Critical Care Medicine, Continental Hospital, for giving the opportunity. Thank you, sir.